So hello today. We have Dr. Meilan Han and Dr. Wes Ely, who was just waiting. There we go, everyone's waiting. And so today we are talking about helping patients better manage their pulmonary health. So with Dr. Han and Dr. Ely, we are going to specifically talk about, how patients and caregivers can really, better manage their pulmonary diseases and conditions. We also want to discuss what inspired them to write their books, which will definitely be a topic that we cover, and also any changes that they're hoping to see in the future. So again, Dr. Ely and Dr. Han, welcome. We're so glad you're here. Before we really begin, I wanted you guys to each have a moment to introduce yourselves. So Dr. Han, can we start with you?
Sure, thank you. So Meilan Han, I am a pulmonologist at the University of Michigan. I'm also chief of the Division of Pulmonary and Critical Care there. I guess I've been working as a physician in the lung space maybe about 20 years now. And what else? I'm also a spokesperson for the American Lung Association and a sort of a passionate advocate for lung health, generally speaking.
Perfect. Thank you so much. And Dr. Ely?
Yes, I am a professor of medicine and critical care at Vanderbilt University and also work at our VA, the Veterans Administration Hospital. And I founded and co-run a center for research here called the CIBS Center, which stands CIBS, which stands for Critical Illness, Brain Dysfunction, and Survivorship. And in this research center, we have about 110 people from 12 different departments at Vanderbilt and the VA, and we're running about 30 studies, NIH and VA sponsored, anything from how do you get people off of ventilators more quickly, more safely, to how do you help them manage the acquired dementia that they got during their ICU stay, to cognitive rehabilitation, lots of long COVID studies we've got going, and we're actually collecting brains from patients when they donate them to us so generously through a program called the Brain ICU Project from the NIH, sponsored by the NIA, to determine the type of dementia cellularly that people acquire during critical illness and COVID. So all those things are happening, and it's such a privilege to be here today. And sitting next to Meilan is a real privilege, and I hope that we can have a fun and fruitful conversation.
Wonderful. Thank you so much. I also just wanted to mention, because we have Sam Giordano here on our panel board. So Sam, I don't know if you'd like to mention anything, but this conversation was actually something that he was inspired to bring together. So we're happy to finally get you two together.
Well, thank you, Heather. I think that respiratory therapists make great partners with physicians, and these two are some of our best and our brightest physicians who see the need to enhance the training and the expertise of our patients to better manage their conditions. So I was delighted to see their books and anxious and looking forward to the reasons that they wrote the book and the objectives we could achieve by using the books and sharing them with our patients. Thank you.
Perfect. Thank you. So on that note, that's a great transition to my first question. So Dr. Han and Dr. Ely, you have both written books that focus on lung health and the importance of educating patients. So I'll have you both answer this question, but if you can tell us a little bit about the purpose of your book, and then also what motivated you to write. And so I guess we'll start with Dr. Meilan Han. I'll show her book. Here is her book, The Breathing Lessons, A Doctor's Guide to Lung Health. So Dr. Han.
All right, well, thank you. So I guess my book journey actually really started at the beginning of lockdown, when I was fielding quite a few questions from the media and from patients on what are we going to do about a ventilator shortage? What does a ventilator even do? How do patients breathe? And I realized that as compared to other conditions, say heart disease, where people at least have some rudimentary understanding of how the organ works, we have generally very poor understanding I think, among our lay public about how the lungs work and sort of what they're up against to keep us healthy. And so it's kind of a long story, but I ended up doing an episode of a podcast called Freakonomics, and an editor at Norton Publishing had heard it and kind of reached out to me and thought that it might be a good time to get some information out there that people could use. And so, in the book, I talk about just some very general stuff that I often go over with patients about how their lungs work and how lung doctors think and some of the tests that we would typically run. But I also, in the process of writing it, really started a journey myself in thinking about lung health from a patient perspective and what that means about how you conduct your daily life and what that means about how you can protect yourself and your children and what can you do that's both defensive as well as offensive to protect your lung health over a lifetime. And I think, unfortunately, a lot of people don't realize that you can actually lose a lot of lung function without knowing it. And unfortunately, a lot of the patients that we pick up are quite severe. And I'm sure Dr. Ely will talk about this as well. But one of the things that we're finding is that a lot of these patients that ended up being hospitalized with severe COVID, many of them actually had some element of underlying lung disease, and in some instances they didn't even know they had it. And so one of, I think, my greatest hopes with writing the book is not just to educate patients, but also to start a bit of a national conversation on why it is that we don't talk about lung health. Why is it that it continues to kind of go under recognized? And even when you look at some of the pandemic preparedness bills and policies that have been put into place, we still don't see a lot focused specifically on acute lung injury. We didn't have great treatments for ARDS even before the pandemic, and so I'm hoping that the moment has not passed. Obviously, we're all anxious to get the pandemic behind us, but I'm really hoping that we as clinicians and patient advocates can sort of use this rather unique moment in time to shed a spotlight on a group of patients that have truly great need and where we need just more awareness, more education, which is why I'm so grateful to you for organizing this. And really, we also need to better educate our government agencies, our politicians, policymakers, et cetera, that lung health and critical respiratory illness has to be prioritized if we're ever going to be prepared for another pandemic. But I'm kind of touching on Wes's stage here, so I'll let him chat about his book.
Well, thank you, Dr. Han. And before we go over to you, Wes, there was one housekeeping note that I wanted to make in case you didn't see it in the chat. If you guys do have questions for the panelists, we're going to hopefully have some Q&A opportunity at the end. So please share them in the chat. And Dr. Han, you are absolutely right. This pandemic has definitely brought an interesting recollection, I guess, or recognition to respiratory health in general. Like, it's your daily conversation, and it still is. So Dr. Ely, let's go to you and talk a little bit about the purpose of your book and what motivated for you to write your book. I will showcase your book. So every deep drawn breath. So please go ahead. But you were on mute. Thank you.
First of all, can you hear me okay? The title is 4 words, every deep drawn breath, and I'll explain it. It's from Steinbeck's East of Eden. It was a real privilege to write this, and Steinbeck is my favorite. These are some pencils, black wings. They're the types of pencils that Steinbeck used to write East of Eden. He used 300 of these pencils to write East of Eden. And there's a chapter in East of Eden where he describes the highs and lows of the human condition and the beauty of the body and the way that the lungs intersect with the nerves, intersect with our skin. And it's just some of the most beautiful prose ever written. And so in that section, I chose that for the epigraph to the book. So it's at the very beginning of the book. And it says these words, every deep drawn breath. So I drew it from him, and I call the book EDDB. So it abbreviates EDDB. And by the way, no money is coming to me from this book. Every penny goes to COVID survivors and their families. And the reason for that is we're establishing an endowment with all the proceeds from EDDB, because the SIB Center is hiring social workers. We have about 5 support groups a week where we take care of ICU survivors, and they cry, they moan, they tell us how they can't pick up the pieces of their life. And we're realizing they don't even know how to apply for disability oftentimes. They can't get through the insurance maze. So we're going to use the proceeds from EDDB to hire social workers for your patients, any patients around the country who can come to our support groups. They actually come from Japan and England and India, Latin America. I think the social workers will be most helpful for Americans, of course, because our systems are different. But anyway, that's a bit of a background on what went on here. And let me just tell you 2 stories. Ode to Mr. Parks, and he lets me use his name. Earlier today, I got a call from Mr. Parks, and he was the first patient that I cared for with COVID in the VA ICU after we had finished our clinical trial about baricitinib. And this is a man, a Black man from Kentucky who got COVID, went to an outside hospital. He did not have underlying lung disease, but he had hypertension and he had some mild diabetes. And he went to a hospital and basically was parked there for a week, didn't even get steroids, completely infuriating. Shows you how the pandemic amplified the discrepancies in society between some people who get good health care and some people who don't. And he transferred to the VA. He was like a sinking ship, a diving plane. And we put him on steroids and baricitinib because I just found out the day before that Barry works as in conjunction with steroids. And he kind of went like this and came out and lived. And he called me today. He's still on oxygen. It's been a year. He's got cryptogenic organizing pneumonia. He's got scarring in his lungs, and he has bad lung health now. And so your book, Dr. Han, couldn't be more appropriate. And thank you for taking the time to write this important book. I know I'm gonna get a copy for him, and I know he'll be benefiting from your wisdom and your data and the way that you put it all together so beautifully in your book. And the reason I wanted to start with Mr. Parks was that I wanted to paint a picture for you all of, you are the AARC. You are a group of highly trained, extremely knowledgeable respiratory care practitioners. And I have the utmost respect for you and how you have revolutionized the way that we care for people in the hospital with spontaneous breathing trials and getting them taken care of during COVID, but also getting them safely off the ventilator. And I'm going to say one more story and then I'm going to be quiet. When I was a young academician and I had dark hair and no gray hair, I wanted to go into academics. And I knew that I wanted to answer questions that might help people that I would never meet. And that was kind of my motto, which was, help improve the lives of people that I'd never meet. And my actual motto is, it's better to light a candle than to curse the darkness. And so in trying to light a candle, I went around the hospital asking people, what would be a good study? What would be a way that we could light a candle? And nobody was giving me an idea, and I was getting increasingly frustrated. But one day in the New England Journal in 1995, I was on the Stairmaster reading my journals, and Andres Esteban's paper about once a day versus multiple times a day, T-tube trials, et cetera, came out. And in the very beginning of the results section, it said that 75% of the patients who they screened for the study were ready to be extubated at that time. And I thought to myself, oh my gosh, why were the vast majority of people ready to be extubated? Why weren't they extubated the day before that or the day before that? And I thought to myself, we should do a randomized controlled trial from the moment people get in the ICU to see if we could have respiratory care practitioners screening these patients every day to get them off the ventilator earlier. And I went around the hospital. This is 1995. So most of you probably, I'm sure I'm one of the oldest people on this webinar here. And everybody said, bad idea, stupid, won't work. But I had one mentor, Ed Haponic from Johns Hopkins, and we were at Wake Forest in North Carolina. And the story, I tell this story in here very clearly of what happened was that we did set up this trial, and we used, the intervention was that we would randomize people to usual care versus a respiratory care practitioner driven protocol. And you know the rest of this. The people who got the SVTs got off the ventilator 2 days earlier, out of the ICU 2 days earlier. They saved $5,000 per patient, and they halved the complications because of you, because of your knowledge and screening of these patients. And we sent it to the New England Journal, and it got published there. And we now have these things called SBT, spontaneous breathing trials. Well, the way it connects in with Mr. Parks is that at the very first, and what I talk about in EDDB is that we published this in the New England Journal, and at first nothing happened. Nobody started doing all these SBTs. It all just seemed to stay the same. That was in 1996. For the next 20 years, I worked to do more randomized controlled trials, partner with people at the University of Michigan. Some of your faculty are the ones that we did the subsequent trials with, Dr. Han, Bob Heisey, et cetera. And we have all come together as a community to figure out how do we get people safely off the ventilator. And we went from the breathing trial to the awakening trial, to the delirium management, to the choice of drugs, to the early mobility, to the family. And we together around the world, we built the ABC DEF bundle. And we now have proven that in over 30,000 people, 400 papers, and we know how to do a better job with them. But the respiratory care practitioners are the linchpin of the whole thing. And I just want to thank you for what you do. And your story is told in EDB clearly through patient stories. I recorded all their stories with this device. I transcribed them. I've got drawers full of transcriptions here. You can see all these transcriptions of the stories. And this is by no means a memoir. What it is a book of narrative nonfiction of patient stories. And I hope that you find your heart there, because that's where we learn the bravery of these patients, is listening to their stories. And that's why I wrote the book, was to tell their story.
Wonderful. Thank you so much, Dr. Ely. I am not a respiratory therapist. I don't think I actually introduced myself. I am Heather Wilden, Director of Communications here at the AARC, but I adore getting to tell the amazing stories of respiratory therapists everywhere. And so thank you to you and Dr. Han for all that you are doing to help support the respiratory therapy profession and the vitalness that you are finding it to be. It is wonderful. Thank you so much. I'm actually going to continue with you, Dr. Ely, to my next question. And I think you've already been starting to touch on this, but, the topics in your book definitely are focusing on, for both of you, patient care and education, basically to help improve care. So why is it important to bring these topics and concerns to the forefront?
I think it's important because we are all here to reduce human suffering. We want to magnify the human condition and uplift people through really what my definition of mercy. It's mercy is how do you dive into the chaos of another person's life and provide lifting and healing. And I did want to, if you don't mind, I'd like to read 2 paragraphs from this book about this patient's story, because to me, it's not about me, it's about these stories. So this is a woman that I cared for on the ventilator. She was on inverse ratio ventilation. She was paralyzed, sedated, and she survived. And I thought, oh, she's fine. This is before I really understood PICS. Her name is Teresa Martin. And then she came back to see me 2 months later in the clinic in an outpatient setting. And I thought it was going to be a high five. Oh, Dr. Ely, you saved my life. You're so awesome. But I want us all to keep our mind on what is happening with our COVID patients and with our ICU patients. And here's what happened when Teresa came back. Almost immediately, Teresa's mom asked me, why can't she bend her arms at the elbows or move her shoulders? Her mom looked drained, more tired even than when she visited her daughter in the hospital. We ran through a litany of other problems that Teresa was having, during her survival. She couldn't swallow properly or sleep or go to the bathroom alone. She couldn't shower or dress herself. She could walk only a few steps at a time, and stairs were impossible. The idea of returning to her old job was exhausting. And the list of ailments was dizzying. I had no immediate solutions for any of it, and even less of an understanding of where the problems were coming from. So I did what I knew how to do. I ordered blood work and x-rays. Labs didn't show anything alarming, but the x-ray images of her arms and legs revealed large calcium deposits in her elbows, shoulders, and knees. Teresa had heterotopic ossification, a condition in which bone develops where it shouldn't due to extreme inflammation and prolonged immobilization. It was as if she had rocks growing inside of her joints. I'd never seen anything like it before, and I didn't know what to think. Teresa didn't react at all when I showed her the disturbing images, but her mother nodded in affirmation, as if she now had permission to talk about her other concerns. She told me Teresa's brain wasn't working properly, that she'd forget things, people's names, that she'd grown afraid. Miss Martin stopped and shifted in her seat. She's a completely different person now. So the reason I chose to read that in answer to your question is just that we have to educate one another. We have to make it clear that we are not just caring for a patient with lungs. Even though Dr. Han and I both have lungs on our covers of our book, we're caring for an entire human being with all the organs, including the brain. And if we can keep in mind that this is the entire person we're caring for, I think it will help us to avoid what I call the depersonalization chamber of medicine, where somebody comes in with a lung problem and I just think, oh, I'm caring for a pair of lungs, but that's completely inadequate. And I think COVID has made it very clear to us that we've got a much larger charge ahead of us. And I'd love to hear what Dr. Han has to say about any of this, but that's the purpose of our education here, is to amplify the human condition.
Perfect. Thank you so much. Dr. Han, just for you, the same question, why is it important to bring these topics and concerns to the forefront?
Gosh, there's so much going through my head right now. One of the things I think, relevant to what Dr. Ely was talking about with respect to the fact that there's all this we're learning about patients with lung disease, patients who have recovered from critical illness, and but yet there is so much more work to be done. And lung disease was actually the #1 cause of death in the United States last year. That's the first time that's ever happened. And I firmly believe that we would have been in a much better place had we had better awareness and better investment into understanding lung injury, into helping critically ill patients. Not that a lot of great work hasn't been done, but when you compare us, say, to my husband's a cardiologist. So when you compare us to the cardiologists, in many ways, we are light years behind in terms of early disease recognition and treatments. And so I actually spent some time really doing a deep dive into this problem. And because I was really bothered, why are we so far behind? And it goes so far back. When you look, for instance, when the early spirometers were invented, they weren't slick, they were functional. And in fact, John Hutchinson, who invented one of the earliest models, was an actuary. He was a physician, but he also worked for a life insurance company. He knew that lung function predicted survival, but yet, it wasn't, his machine wasn't something you could easily pack up in a bag. But when things like blood pressure cuffs came along, and particularly when they were combined with the use of the stethoscope to get both systolic and diastolic measurements, physicians in the early 1900s thought it was a really cool thing. And it was something that helped distinguish their skill set, and they just adopted it. And then ultimately, we had studies like Framingham, where we had lots of blood pressure measurements, and we were able to figure out that things like blood pressure and cholesterol were really important. And if we could treat those things, we could prevent strokes and heart attacks. And And so we developed this evidence basis for many of the advances we've seen in cardiology very, very early on. But the pathway for understanding respiratory illness and coming up with treatments has had so many kind of, I think a bit about about the poem, two roads diverged, in the wood. And when you look at what's happened with cardiology versus what's happened with pulmonary, we've had very slow adoption. We don't have the evidence basis. And we've just also suffered from generally poor awareness and unfortunately a lot of stigma. So we've seen a lot of, in my opinion, part of the reason why we haven't seen the levels of funding that we need is because if you think about the patients that have lung disease, generally speaking, they tend to be lower socioeconomic status, rural areas, sometimes smokers. And so they tend to not be a group of people that really are empowered or enabled to speak up for themselves. And so I feel like it's sort of a convergence of all of these factors that has gotten us to the place where we currently are. And it is sort of my desperate hope that through books like Wes's, where we can really try to bring some of these issues to the forefront, that we can kind of take the message to the people, take the message to the public, partner with our allies in respiratory therapy to get the message out that, in some ways I'm not totally done, but in some ways I'm sort of done talking to doctors, right? It's not really gotten me very far preaching to the choir. So we've got to take the message to the people, got to take the message to the public and help people really understand where we're at. I wrote an op-ed for the LA Times, and the LA Times editor took out my favorite quote in the article, but I'll tell you what it was, which is this: I believe that lung health is the Achilles heel that we did not know that we had until the COVID-19 pandemic hit. I don't think we all realized how fragile our lungs are. And I don't think we realized that because of things like climate change, air pollution, respiratory viruses, et cetera, there's a lot of damage that often is percolating under the surface. Sometimes the body can heal it, sometimes it can't though. And that's gonna make you even more susceptible to insults like COVID-19. And it's only getting worse. I believe that this is the tip of the iceberg. So, it was sort of many of these factors that I was thinking about, when I wrote the book. And it's my, really sincere hope that not only, potentially could it help individual patients as they're trying to figure out their own journey to either recovering from a lung issue or hopefully preventing lung issues. But like I said earlier, really hoping that we can just sort of, use the pandemic, use these stories, the book, et cetera, to really engage the public in conversations about how we globally can protect our lungs. And it's not just me in the doctor's office. It's conversations with teens and middle schoolers about vaping. It's conversations with elementary schools about adopting anti-idling policies. It's conversations with the government about pollution and things that we have to do to create healthy environments for our communities. So there's so much work that needs to be done. But like I said, I'm just very honored and excited that the AARC is engaged in helping with this work.
Wonderful, thank you so much. So on that note, and on this, this purpose or this concern that there is so much work to be done. And you talked a lot about why it is so important. And I think you've already perhaps even covered a little bit of my next question. But if there's any more you want to add. So my next question is, what changes do you hope to influence regarding patient care? I know you, and I'll start with you, Dr. Han, but I know patient education and caregiver education is definitely something that you've been discussing. So, but is there anything else that you're hoping to see change or that you can help influence regarding patient care?
You know, I've recently been trying to sit down with several organizations to think strategically about the types of changes that we need to see and who can we engage in the fight. And there's so many issues. It's in part, you know, patient awareness, just even knowing to ask for spirometry. We know, for instance, for COPD, one of the most common lung diseases in this country, only about a third of patients have had appropriate diagnosis. So it's just crazy. And we can't even, as health systems, measure whether we're screening or treating appropriately because we don't even know where the patients are and nobody's actually even getting the metrics you would need to determine quality of care. So we're so far behind. So it's part of it's public awareness, part of it's engaging with organizations that set metrics for quality standards. It's working with the health systems and insurers, but it's also working with government agencies to ensure that we have better funding for understanding lung injury, lung repair, you know, the exact stories that Wes was talking about. We would really be so much farther along in this fight if we had better investments into that to begin with. One of the things that has been frustrating for me is if you know, we've had great investment into COVID vaccines. That's great. COVID treatments, also amazing. But we need greater understanding about how the lung heals, and that's expensive. Clinical trials are expensive. I'm sure Wes can tell you more about that as well. But it takes a lot of manpower to get this done, and we need the same level of investment that we've seen in other areas that have made progress, like diabetes, like like cardiovascular disease. So there's just so many buckets of, I think, areas where we really need more attention and more focus. But like I said, I think where respiratory therapists come in, they certainly can help us with engaging patients, patient education, but also, I work with respiratory therapists on our quality committees, on engaging with the hospital, on just our general approach to finding patients and ensuring patients are getting, kind of spirometry, et cetera. And so I think there are many respiratory therapists that have leadership positions in their health systems. So I think there's many places where respiratory therapists can kind of help to lead this type of charge within their own health systems and communities.
Wonderful, thank you so much. Dr. Ely, is there anything that you would like to add on this question about what changes do you hope to influence regarding patient care?
Sure, I will just use an example, a practical example of what I hope that the 50 or some odd people on this call can hear and think about. If any of us wants to go from LA to New York, we're going to get on an airplane and our pilot is going to use a safety checklist to get us there safely. And we depend on that. We know that they're up there in that cockpit doing that. We don't even question that. Well, when the Society of Critical Care Medicine partnered with the AARC and other national groups in 2013 to 2018, we did such a great job of using that safety checklist around the country that we actually, as a barometer of all this, we actually watched delirium rates in ICU ventilated patients come down by half. We went down from 70 to 80% for ventilated ICU patients, all the way down to the 40% range across numerous new studies that came out in 2018, 2019. So that had never been done. In 30 years of critical care that I've been doing research, the rates had always been high, and we accomplished something. We measured how often we were using that safety checklist, and it was 80% And we did another point prevalence study, and that measurement of 70-80%, that was in 40 countries around the world. This is not just at one center. This was all over the world. We were getting 70-80% compliance with these bundle steps, which is basically just waking people up, checking them off of sedation, doing a breathing trial to see if they can come off the ventilator, managing their delirium, mobilizing them, and having their family at the bedside. That's essentially the checklist. During COVID, it was a house of cards. It collapsed in our point prevalence study to 10 to 20%. So what if you were getting on your airplane and 10 to 20% of the time, the pilot was doing the safety checklist, but you didn't know it. So now make yourself the passenger in the airplane. That's our patient. They're in the ICU. They come in the ICU. They don't know that we're not doing the checklist. They have no idea. They think I came to Vanderbilt. I'm getting the best care. I came to, just name any great institution. And I'm pointing the finger back at myself. I'm complicit. We had people behind the glass. We were afraid. We didn't have enough PPE. We had no visitation policies for a while. I don't want to live that way anymore as a doctor. I don't want to be that way as a healer. And I know that I was not being a complete healer during COVID and when this all fell down. So what do I want to see happen? I want us to rebuild. We have to rebuild this whole thing. And I'm ready to take it on. And all of us are. We have to be. The therapists, the nurses, the doctors, the leaders, the clinical nurse specialists, the PharmDs, the whole schmear. We're working right now with the SCCM and the ICU Liberation. We're working with the American Thoracic Society. I want to work with the AARC. I want us to go out and teach each other that, hey, we've got a whole new fold of people in the ICU now. A lot of respiratory care practitioners said, I'm burned out, I'm out. And COVID just blew everybody up. So we have young people who came in and they think this is the way you practice medicine. You put them in, you put them on a benzo drip, you mobilize them. No, we know that's not the best way. We know that hurts people. That actually increases death. It increases length of stay. It magnifies delirium and coma, which then brings on PICS, which is the post-intensive care syndrome, PTSD, depression, acquired dementia, and muscle and nerve disease. So end of answer, I want us to rebuild what we know works and to use the data that we accrued from 2000 to 2019 and really to use the power of human story so that each of us digs deep in our own units and finds a Mr. Parks or a Teresa Martin and says, this is our North Star. And that is who will guide us and lead us, is our patients. And we're going to do right by them. We're going to do our checklist. We're going to be safe, and we're going to magnify them and have their family there at the bedside. We're going to wake them up every day. And it's kind of, this may sound heretical, but the lungs can't lead everything because the lungs are so beautiful as an organ because they're connected to the rest of the body. If you read a New England Journal CPC, I've been doing this for 30 years since I've been reading the New England. Every time you read the New England and they do a clinical pathological conference, CPC, the mystery cases, it always involves the lung because the lung is a centerpiece organ. That's why Dr. Han wrote her book, but it's a centerpiece that connects the rest of the human body. And that's why I want us to spend so much time rebuilding safety in the ICU.
Wonderful. Thank you so much. By the way, I love, we have Kelly in the chat. She, once you talked about rebuilding, she shouted out, amen. Yes, we need to rebuild. And so on that note of rebuilding, which I think just again, with both of you talking about the pandemic, there's so much that sheds so much light, I think in healthcare and beyond. So there's so much that is being rebuilt. And Dr. Ely, I loved your metaphor about patients essentially being the North Star. Because that's why all healthcare professionals do what they do. It's for the patients. So I love that metaphor. So how can respiratory therapists and other healthcare professionals really, support patients and caregivers to better manage their pulmonary diseases and conditions? Kind of on this theme that we've been talking about, any insight that you want to share would be appreciated. And we can start with you, Dr. Ely.
Me? Yeah, this is where it gets so beautiful. Medicine is such a privilege to be a part of this, because we are on this bus to help get people back home to their loved ones. I mean, the entire journey that we want them to be on is, you know what? We know we're not the centerpiece of your life. The people you love are the centerpiece of your life, but we will play a part in getting you back there. And so if we're going to, I had this one young woman, she came to me in the ICU, and 2 months later, she almost died. She was up there a month. And then she came back 2 months later, and she looked at me and she pointed her finger like this, said, "You didn't do your job. You didn't do your job because I can't raise my kids." And I was so convicted, because I know I kept her in the bed too long. I kept her sedated too long. I hurt her. And I had benevolent intent. And I say this in the author note to EDDB. I say, in medicine, we have benevolent intent, but that's not okay, because we have to achieve beneficence, not just wishing good, but actually doing good. And so I think that we can take the respiratory care practitioners can say to themselves, we are a critical cylinder in the machine of this recovery process for this patient. And I'll make a short answer here. My short answer is this. That woman that wanted me to have gotten her back home to take care of her babies in full force, which she couldn't do because she was disabled. Remember this, for all of you respiratory care practitioners, recovery begins on admission. Recovery begins on day one. And I got that wrong for many, many years. And that's the story of the patients in EDDB, is that I felt shame and guilt because I was carrying around this knowledge that I knew I wasn't doing what was good and right, but I couldn't understand what it was. I didn't understand the way out. But you are the people who can say on rounds every day, I tried to do an SBT this morning. They failed miserably because they're on so much damn sedation. Can we turn their sedation off? Because I need to do an SBT because I think I can get them off the ventilator. And the nurse has to hear that connection between the therapist and the nurse and the doctor. And we need to stand up for the patient and not just say, oh, well, I get it. 2 days ago, they were bucking the vent and they were desaturating. So we've got them at a RAS -5. Well, that was Monday. It's Wednesday now. That is a whole different ballgame. Let's turn this stuff off, see what we can do, and the therapist can drive us. So recovery begins on admission.
Wonderful, thank you. So Dr. Han, I will pass it on to you. How can RTs support patients and caregivers to better manage their pulmonary diseases and conditions?
Well, I guess maybe I'll focus on more of an outpatient perspective then. There was much that was both dismantled as well as accelerated during the pandemic. So my usual clinic where I would have my respiratory therapist right with me to help me doesn't happen when I do virtual visits but at the same time, we saw this huge advance in our ability to do virtual care. Which has been good in that we can better provide access to some of our patients, but we still have those who still struggle with some of the technology and social isolation that comes with being separated. And then the other problem is, how do I engage my MA, my nurse, my respiratory therapist in a visit when I'm doing virtual care? We've also seen our rehab programs get shut down. We've seen difficulty just doing pulmonary function testing because of concern for aerosol generation. So much of what we have normally done has not worked, but at the same time, we have started to begin to think about workarounds. And so I would love for respiratory therapists to help, just think and brainstorm as we move forward. How do we retain, not throw the baby out with the bathwater? We keep the good, move it forward, and figure out how to better incorporate it into whatever this new normal for healthcare will look like. We still don't have great data on how much remote monitoring helps or doesn't help. Should we be doing remote PFTs or not? How is pulmonary rehab best delivered? whether the long-term benefits are better, whether it's delivered in a brick and mortar versus an online program. What are the key components for a virtual program, for instance? How do I incorporate respiratory therapy into my virtual visits? I think there's just a lot of open questions right now. There's a lot of research that needs to be done, but I think as you were pointing out, Heather, it is really time now to re-engage. Most of our health systems are fully open. Hopefully most are not overwhelmed with COVID right now, although I just noticed a few minutes ago, my own hospital numbers are starting to tick up again. But we at least understand sort of the general mitigating procedures now. So I think we all, I would welcome conversations, and I'll continue to work with my own group at the University of Michigan on how do we move forward to best deliver care sort of in this new era. But as Wes said, it has to be patient oriented, patient focused, and what is the best for the patient. And sometimes that is not having to worry about getting into the hospital, but other times that is actually being with other humans and getting to exercise and talk and chat and be in a support group physically with other people. So I look forward to continued discussions about sort of what is the best way forward for our patients and what does that look like, sort of, clinic by clinic and practice by practice.
Thank you. That's perfect. Just as I'm kind of wrapping up my questions, my final question for you is, what takeaway piece of inspiration or knowledge would you like to leave with today's conversation with people that are listening today? And we can start with you, Dr. Han.
Okay. Well, I'm actually going to just read I'm going to read just the last chapter for the book, and hopefully that will sort of sum up my thoughts on this. So now is the time to invest in research focused on understanding lung disease and developing treatments so that we will be better prepared in the future. Threats to lung health were already lurking even before COVID-19. Air pollution in certain parts of the world were already at dangerous levels. We must take air pollution and protection of air quality more seriously than we ever have before. The number of youth using tobacco products has reached epidemic proportions. We must proactively protect lungs of our children and our adolescents now. And as a medical community, we've really become complacent. We need to recognize the warning signs of lung injury much earlier. Spirometry is not just a test of lung health, but rather of human health. It's the fifth vital sign. The number of threats to human lung health increase daily. We can do better. We must do better.
Thank you. That is wonderful. Thank you for sharing that. Dr. Ely, is there any takeaway piece that you would like, or inspiration that you would like to leave?
I'll end with a story too. This one is not in this book because it happened to me after COVID. It happened to me just a month ago. I had a patient a month ago in the ICU, and she was on a high flow nasal cannula. The respiratory care practitioners were doing a great job taking care of her. She was getting superb AARC backup, but she was getting sicker, and I knew she was heading towards the ventilator. And she said to me across the room, "Doctor, can I tell you why I didn't get vaccinated?" And I said, this is your story to tell. I said, it's up to you. And it doesn't matter. But she started crying and she said, "First, can you please tell my family that I was wrong and that I want them to get vaccinated now?" And I said, absolutely. I will tell them. I've talked to your daughter earlier today. I'll make sure that they all know that you think you were wrong. And by the way, our visitation is wide open now at our hospital. We don't have any closed visitation anymore. Even in the COVID rooms, they come in the PPE. So it's good. And the non-COVID rooms are wide open back to the previous normal. So if your hospital is not there, advocate, please, because families are part of the healing plan. Family is not a luxury. Anyway, I knelt down beside her. I held her hand. I looked in her eyes, and she started crying. And she said, the man on the TV said that the government was trying to depopulate society of people like me with the vaccine. So I just thought, wow, she's a victim. This woman is a victim of misinformation. And I said to her, and this is my closing point, I said, I'm here with you. I'm not leaving you. We all are, and we're all going to take care of you. And the respiratory care practitioner came over and grabbed her other hand and said, it is our privilege to care for you. We love you, and we want to be here for you as you go through this. So that was the partnership between physician and respiratory care practitioner. And what we were doing was, and there's a whole section in every deep drawn breath about this, this was compassion. And I am no bastion of compassion. I mean, it's not like I am the master of any of this. I am full of flaws as a physician. Every day I learn from the nurses and everybody else around me how to be more compassionate. But the point I want to make to you is this: compassion is something that we are not born with. It's something that can be taught. And we can make, we know from science that you can make a compassionate statement like the one I told you that we made with this woman in about 30 to 40 seconds, which can change the course of somebody's healing. And so if all of us as respiratory care practitioners, nurses, therapists, PharmDs, doctors, if we all remember that we can actively pursue more compassionate care, then I think that we will find that we become better healers. And that's what I want to leave us with, is that all of us can do this and become better, complete healers. And COVID, if anything, shone a light on this need of ours to become better healers. There was a thing in the chat that said, how do we do this when our young practitioners are leaving to make higher money somewhere else? Exactly. They are leaving, but the people who come in, we have to take who we've got and train them and emphasize this is our way forward. And I think that we can do it.
Wonderful. Thank you so much, Dr. Ely. Yeah, compassion is so important. I myself have not necessarily been in the hospital too much. I was in the hospital last fall. I gave birth to a baby, and I was so appreciative to all the healthcare professionals that would come in and help me out, because I was in there for a week. So compassion is definitely super important, and that education. People want to know what's happening, and they want to be able to trust what you're telling. And so I think compassion behind that really helps. So Dr. Ely, you actually touched on one of the questions that was in the Q&A or in our chat. So I'll just go over, we had one other question that was from, I believe, Gary Kaufman. Let me see if I can go back up to his. So he mentioned that a recent article was published documenting the value of RTs in the home and in the home, and the outcomes were fantastic in terms of reducing exacerbations. He just wanted to know if you were aware of any other studies that show respiratory therapy value. I don't know if you know anything off the top of your head. I'm
not aware of it. And I hate to tell you this, but my phone is blowing up, getting me called to the ICU. So I've got to leave to get back to the unit. So I hate to say this, it wasn't planned, but I'm seeing why they're needing me, and I need to go. So well, I'm going to get out of here, and thank you all for this wonderful day. Email me if anybody has any questions. You can get me through the website at just icudelirium.org. And Dr. Han, it was a privilege to be with you today.
Thank you, Dr. Ely. It was a pleasure to be with you as well.
Bye, everybody.
Thank you. Well, then I will pass that baton of a question to you, Dr. Han, if you happen to know of any other studies or anything that promotes respiratory therapy value or therapist value.
Oh, I can't quote tons of studies off the top of my head, but I'm sure there are. Most of the work that I've been involved with has been around sort of multidisciplinary teams and caring for patients in the hospital, as well as what this article relates to, which is trying to reduce readmissions. And I think there is data around, having multidisciplinary teams in the hospital that include, often are respiratory therapy driven, respiratory therapy led, that can improve outcomes like readmissions. At the University of Michigan, one of the things that we implemented was We first of all had standardized RT education in the inpatient setting for instance, talking specifically about COPD for patients who were in for exacerbations. And then the other thing we did was to create a transitions clinic where patients would be seen between 7 and 14 days after. That also included respiratory therapy evaluation to make sure patients were using their inhalers correctly, and help me evaluate for patients that might need non-invasive ventilation, or also troubleshoot if the patients were sent home on some type of non-invasive ventilation. And so I have, found that in my own practice, having that RT partnership in the hospital, having RTs on the quality committee, having RTs physically present in the clinics has been so valuable. Sometimes I know it's hard to argue with the hospital about having RTs everywhere, because they're always trying to look at the immediate bottom line and can they bill and things like that. And we really have to help the health system where it's possible to see the programs more globally. And that respiratory therapists represent crucial members of the team if we want to really deliver the best care possible. So I know I've been super lucky, but I know every situation, every health system's a little bit different, but there's been clear value from my perspective in having respiratory therapists, involved in all aspects of my practice.
Wonderful, thank you so much. So Dr. Han, we are basically up at the hour, and I just want to again thank you so much for taking the time, and thank you to Dr. Ely. I know he went ahead and had to head out to the ICU, but thank you to you both for taking the time today to discuss this topic. Before I completely wrap up, Sam, is there any last message that you'd like to share at all?
Oh, I'll only give us all a saying I heard when I was a kid, which is, a problem is an opportunity in disguise. And I think that COVID has pulled the cover off of a major problem, and that we as respiratory therapists need to focus on lung health as well as treating lung disease. We've done that to a limited extent, but I think as Dr. Han has indicated, there's going to be more that's required now because of a variety of changes. This is an opportunity. We will have challenges. We'll have to get through the human resources shortages, but these do not last forever. So we need to do as much as we can, even though we're stressed out right now, because eventually this will pass and we'll be able to do more. And thank you, Dr. Han, for the book and for agreeing to talk to us today.
Thank you.
And thank you, Heather, for moderating the show for us there. Thank you.
Thanks, Sam, and thank you, Dr. Han. And thank you to everyone who participated today. I think it was a great conversation. We will be sure to get this, we've recorded it today, so we will work on getting it posted to our site. And we'll try to share it out as well.
All right, thank you.
Bye, guys.
Thank you.
Thanks.